Okay, I think we'll get started. So, good afternoon and welcome to this week's NDARC webinar. My name is Sarah Farnbach and I'm a researcher here at NDARC, and I have the great pleasure of being today's chair. So today we'll be hearing from Emeritus Professor Shane Darke, who is a local legend around NDARC. Many of you will know he has a long-standing career doing research around a range of drug and alcohol related issues. And he's kindly offered to do a webinar for us today, looking at clinical characteristics of heroin overdose deaths amongst older adults in Australia. So it'll be a really interesting webinar. So we thank Shane for coming back and joining us on the webinar today. After the webinar, we're going to be joined on the panel by Professor Joe DeFleu, who is one of Australia's leading forensic pathologists, a good friend of Shane's, and he's been working with NDARC for a long time. He's an expert in toxicology and overdose, and I'm sure we'll have lots of interesting ideas to discuss after Shane has finished talking. So after the webinar, if you've got some questions that you'd like to pose to either Joe or to Shane, please just pop them in the Q&A and we'll try to get through them, as many as we can, in those few minutes after the talk. Yeah, so please use the Q&A function. We'll try to get through those questions. So before we begin, I just do want to take a minute to acknowledge and to pay my respects to the traditional custodians of the land where we're meeting today, which in my case is from the Ngunnawal and Ngambri lands, and to pay our respects to elders past, present, and extend the same respect to any First Nations people who are joining us here today. Okay, I'm going to stop and I'm going to ask Shane to please join us. Hi, Shane, I can see you there.
Thank you, Sarah, for that lovely introduction, and it's a pleasure to be back treading the boards of the ballrooms of Mars.
Thanks, Shane. All right, I'm going to hand over to you.
Cheers. Well, ladies and gentlemen, the first thing I'd like to say is, why do we study drug-related death? Well, as I've opined on many occasions, we do so because the dead have much to teach the living. If we can understand who's dying and why they're dying, how they're dying, then we have a better opportunity to prevent these deaths occurring in future, because essentially the vast majority of these deaths were preventable. Each one of them is a tragedy and preventable. And secondly, I think we owe it to those who are deceased and to their friends, relatives, etc., to provide that understanding and to actually be able to say, well, this is what happened, and this is hopefully how we can learn to avoid it in the future. Why would we look at heroin deaths or opioid deaths more broadly? Well, one, it's been opioid dependence and mortality and morbidity has been a major problem in this country since at least the 1970s. It changes in form, but it never really goes away. And if we look at opioid users or heroin users in particular, the mortality rate is something like 15 times that of people who are matched of the same age and gender. And why are people dying? Overdose or poisoning. It's very different when we look. I suppose I should say, well, what is an overdose? Well, it's basically opioid overdoses are all about respiration. Opioids and heroin in particular is a powerful central nervous system depressant. That is, it depresses the breathing response. And this occurs even amongst people who are highly tolerant. People who have been using for years can get down to 4 breaths per minute. And I think it's important to note that there's good work out of the UK that shows that that's quite extended. It takes a while for it to be reset, even after you've had this, you've gone through a lot of the metabolism of the opioid. There can be this residual depression. So really what an overdose death typically looks like is a cascade down into lower respiration rates, loss of consciousness, coma, and in the end stage death. Now, it's very different than when we look at drugs such as the stimulants like methamphetamine and coke, which are all about cardiovascular. There are relevant factors of cardiovascular here, which I'll mention, but really it's about respiration. Now, you might be saying, well, Shane, why are you looking at heroin? Isn't heroin a problem that was solved? Well, the bottom line is no, it has not gone away. The idea that somehow we had an epidemic in the 90s, which we did, and then suddenly methamphetamine came in and heroin went away, or oxycodone came in and heroin. Those things happened, but it didn't go away. Now, there are questions to be asked about this, I mean, interestingly, when we've been doing, and particularly with Joe and I, have been doing work on heroin overdoses since the 1990s, we were told there was nothing to study. We were told that it was all young, inexperienced people didn't know what doing. There was impurities, massive increases in purity. It was completely unpredictable. And we've spent the last 30 years or so basically showing all of those things were wrong. And we're still studying and learning things today. Now, we did a study that came out last year or so, where we looked at deaths in Australia that occurred from heroin in the period just between 2020 to 2022. There were 610 deaths involving, that's toxicity deaths, involving heroin in that period. That's not a drug that's gone away. Now, of course, drugs, we get new opioids like oxycodone came in, we get the nitazines, we get your tramadols, etc. But heroin bubbles away. Now, but having said that, the characteristics have changed over time. The average age of people who are using heroin has increased for two reasons. One, there have been fewer but not non-existent new people coming in, and the existing population is using much longer. When opioids first became a big deal, like in the 50s and 60s, there used to be a concept of maturing out, that people who would mature out by the time they're in their 30s. And that may well have been the case in that case. But with the advent of heroin, opioids are very sticky drugs. So there tends to be a long cycles of relapse, basically use, cessation, treatment, relapse. That's not to say everyone keeps on using forever, but there's a significant portion of people who will use for decades. And that is reflected in overdose deaths. Back last century, terrible thing to have to say, when we looked at deaths in the 1990s, the average age was 31. The very oldest cases were in their 50s. Now, that study that I just mentioned, which I'll show you the reference later, when we looked in the early 2020s, the average age was 42, and the oldest cases were now aged in their 80s. Now, it's hard to look at what maturing out means when we've got people using into their 80s. Now, in that study, interestingly, there were two things I just would note about age. One, 90 of the deaths were under the age of 30. It's not that everyone stopped using heroin who was born, say, in the 1990s, but 169 were over the age of 50. Now, that shows you two things, as I said, young people still coming in, older people keeping on using. Now, there does appear to be differences with age. And this is one of the things we're trying to understand. Now, one of the things seems to be that more older people seem to have a shorter survival time. Now, I'll just explain very briefly. When you take heroin, diacetylmorphine, that's never what's found in the blood. It's what's called a prodrug. is rapidly metabolized into 6 monoacetylmorphine, 6-MAM. Now that is then metabolized into morphine and the conjugates in about 20 to 30 minutes. If 6-MAM is still in the blood when the person's dead, it means we're pretty certain that death was within under 30 minutes, probably under 20 minutes in that period. If it's completely metabolized, we're pretty confident that it's longer. I should point out, by the way, that there usually is that some time. The idea that people shoot up and just drop down dead immediately, yes, it does occur, but it's generally a longer period than just immediacy, which is important for intervention. Now, so if 6-MAM's there, it's evident that it was what we'll call shorter survival time, under 30 minutes. Now, when we looked in that study, we divided up into age groups. People under the age of 30, 1/3 of them had 6-MAM in their blood, meaning 1/3 of them looked like they were reasonably quick, which still means 2/3 were longer, sometimes many hours. Over the age of 50, it was over half. So the majority had shorter survival times. And the other thing you can look at for that is pneumonia. Long lives mean, to develop pneumonia, people aspirate, vomit, because opioids cause vomiting. It needs a longer period for pneumonia to develop. And you see the same thing. The younger ones, about 1 in 10 have pneumonia, about 1 in 4 of the older ones. All in all, it seems that more of the older people who have long histories, these are not people who just started using at 60. These are people who have typically started using in their teens and have a use career covering 6 decades maybe. Now, the question is, why? Well, there's a few things you could think about. Firstly, disease. One thing we know about heroin users, it's a hard life, and there's very high, we know that the health of people who are using heroin is significantly worse than that of people who don't, and that gap increases with age. Now, the two major things here are the emphysema, COPD. About 1/5 of people who inject heroin have emphysema. Half of people who smoke it do, but not because heroin injecting causes emphysema, because as clinicians out there would be well aware, almost all heroin users smoke and smoke a lot of cigarettes. And the second one is cardiovascular. So emphysema matters because, remember I said it's a respiratory depressant. If you've got a drug that reduces respiration and you've got less respiratory reserve due to disease, you're at greater risk. The other one is cardiovascular disease. Again, things like smoking. If this matters because sometimes secondary to oxygen deprivation, people can have basically have a heart attack. If you have a compromised cardiovascular system, you're more at risk in those circumstances. And in that study, when we looked at what the cause of death was given, then disease in people under 30, disease was considered relevant to the overdose in 3% of cases. In people over 50, it was 40%. That's a big difference, and it makes you suspicious that something is going on. Could it be differences in toxicology? Well, it's possible. Maybe older people are using different drugs and using differently than younger people. Could it be metabolism? I'm interested to hear what Joe's got to say about this after this presentation. That as you get older, you're not as efficient at metabolizing. And certainly in what's, geriatric medicine, and I hasten to add, I'm in this category, that doctors are much more careful about dosages to older people. You may not be able to tolerate something at the age of 70 that you could easily tolerate at 20. So why did we want to look at those over 65 or 65 and above? Well, it came from another thing. From those studies, one, I was surprised at the sheer number of people that were older, but also Joe had rang me earlier this year and said he was seeing in his forensic practice more people coming into his office, into his work, who were over 65 and had died of heroin overdoses. Now, this raises a lot of questions. I mean, when did this start happening? The media, when the media talks about overdoses, invariably the focus is on young people, you know. And look, every single death is a tragedy, but it misses the focus in that something like about 2% of deaths from heroin occur under the age of 20. It's, you know, as I said, the mean age is in the 40s. It doesn't get the attention. And now we're seeing, are we seeing these older ones? When did they start occurring? We used to just think that wouldn't happen. Who are these people? What are the circumstances that these deaths occurred in? What does their tox look like? What is the role of disease, if any? And survival times. What does it look like? So basically, what did we do? Well, nobody's actually ever looked at this. This is the thing about overdose. It's amazing. No matter what topic you choose, you realize that it's so many things have just not been examined, and that are potentially important. So what did we do? Well, in this country, we've got a national treasure called the National Coronial Information System, which enables us to look at all deaths that come to the attention of a coroner, which will include suspicion of drug-related death in the country. So we can do national surveys and see what all the cases, in this case, are over 65, died with heroin. And we can, this is something that you cannot do in the United States or even the UK. And, you know, the people who run NCIS, people like Jessica and Claire and colleagues, a big shout out to you. They just have this magnificent service, and it's enabled us to understand aspects of drug-related death we never would otherwise. So how do we do it? Well, we looked in, you can code and look for heroin and metabolites or morphine, and it'll pull out those cases. And by the way, this is a study of poisoning. It's not a study of, for instance, people who were using heroin and had a traumatic accident. That's completely different. We also got rid of any cases in which the morphine was attributable to morphine. That is, the person had taken morphine, or it looked like they were being administered in a hospital setting, etc. And we looked for evidence of heroin use, like with 6-monoacetylmorphine in the blood or urine, heroin mentioned in the cause of death, or it's referred to as such in the forensic pathology, coroners or police reports. So that's what we did. And so we picked out all of these cases that came out. So we found 59 cases over the age of 64, 65 and above. Now, when did they first start occurring? Our first question. Well, I think that's pretty obvious. None occurred. The NCIS started in 2000. In the first 10 years, no cases at all. Then again, over the next 5 years, in 2011 to 2015 too, and then bang, we go up to 36 cases from 20. Cases essentially started occurring in the second decade of the century, but started really occurring after 2015 onwards. And I should point out that the 21 to 25, the case rate closures are far lower in those days. Those numbers will rise because in recent years, we can only look at cases that have been closed. The coronial process has been completed. So what we are seeing is a new phenomenon. We're seeing a new cohort of people using. And the thing is, the more people that use a drug, the more harm will be associated with it. And a drug like this, the more the people who use heroin, you will get more deaths. So if you get more use in a particular age group, you will get more deaths. Who were they? Well, this is fairly standard demographics in terms of gender breakdown, mostly male. That tends to be the case that men constitute, that's probably an overrepresentation of men, but more men tend to be living alone and less time for intervention. But that's not an unusual demographic. That looks pretty much what I'd expect. And I'd draw your attention then into the age. 22 of these cases were in their 70s or above, and they went up into the 80s. And as I say, these weren't people that started using like at 75 and just developed the habit. These are people who were long-standing users. And yet, only 7 people were enrolled in a drug treatment program. Now, that has real implications because almost all deaths that occur with drug-related deaths generally occur out of treatment. We'll come back to that briefly. They're documented histories. Now, this is when we see in the documents, the full documents in an NCIS file will give me the coroner's report, police report, the forensic medicine report, and toxicology. Not surprisingly, every single person there was a record of substance use problems, and typically long-standing. And all of these cases had a history of injecting drug use, of injecting heroin use. So these were long-standing people with known problems, but few in treatment. Over a third had a mental health problem. That's, again, probably conservative because it needs to be mentioned. We do talk about comorbidity a lot in this area, and it's valid. I will also, however, say, keep in mind that physical comorbidity is talked about less frequently, but I'm arguing is as important. The circumstances of death. Well, just straight out drug toxicity, about 60-odd%. And again, combined toxicity and disease, 39% of these cases, 23 out of the cases. And what was the disease? Cardiovascular disease, COPD. That's a fair, and as I remember I said earlier on in the earlier study, the people under the age of 30 who died of heroin overdose, that was 3%. Now, this intention, this is the coding in NCIS from the result of the coronial findings. The vast majority were unintentional. That is typical. There were combined intentional and undetermined. I'd say, however, there were fewer intentional than undetermined. But I find there is sometimes a myth, and it gets in the term that I loathe, deaths of despair, because it confuses the fact that it has an implication that overdoses are para-suicides. They're not. Most overdoses are deaths of dependence. And I will say my background too with overdose. This is true of non-fatal. We think there's at least 25 non-fatal or near misses to every fatal heroin overdose. We know to think, yes, intentional opioid overdoses occur, but the majority weren't meant. So I would go back and say, I find that the term deaths of despair is counterproductive in my view. Everyone practically injected heroin. So you got people into their late 70s, 80, whatever, who are still actually injecting. Now you can die from not injecting routes of administration, don't get me wrong, we've documented that over the years. but overwhelmingly injecting is the riskiest form. Almost all occur in a private setting. People tend to be at home more than, particularly at this age. Now you can see there were 29 who were in the immediate vicinity, and yet only 12 of these cases had a medical intervention prior to death. Now that's not necessarily the fault of the people around. Quite often the people were locked away in a room and they weren't aware that they were overdosing. I should point out that only something like 3% of these cases had naloxone detected in the blood. Even if it was administered, the person could be too late to be distributed. So time matters. The toxicology, 2/3 of these people had 6-mem present. 2/3 of these cases looked like they occurred within under 30 minutes. The tox looks pretty standard, 0.2 free morphine, that's what I expect. That doesn't look any different than generally from deaths more broadly. But I just point out that sometimes it goes down to 0. There were a couple of cases where they fully metabolized the morphine. We had other conjugates of morphine there, but they'd survived long enough to do that. But there were still people who were using quite astonishingly high levels of you can see up to 3.7 milligrams per litre. Now, one of the things we've shown over the years is quite clearly the role of other drugs, particularly other depressants. You add a number of depressants together, hypnosedatives like benzodiazepines, gabapentinoids, etc. Or not the Z-class hypnotics, for example. Sorry, not the gabapentinoids, but they reduce respiration. They have CNS depression. Opioids were there in 1/3 of cases. About 87% had other drugs on board. That's fairly standard as well. I will say, interestingly, the alcohol is lower than it used to be back in the day. We used to see about 40 or 50% of people with alcohol. Now, whether that's the result of long-term liver disease, I'm not certain. But you can see, again, these are polydrug deaths. Most drug-related deaths are polydrug deaths. Now, there was only, unfortunately, well, not unfortunately, we had autopsies were conducted and available for 32 of these cases. Of those, because quite often they don't do an autopsy, the cause of death seems obvious. Coronary artery disease, over half had severe. That means that 75% of at least one coronary artery has been stenosed, narrowed. Cardiomegaly in 1/3 of those cases, enlarged hearts. Scarring, visible scarring, that's indicative of previous ischemia in a quarter. And yet bronchopneumonia in a minority indicated, which is consistent with deaths mostly being reasonably rapid. And you can see a range of other things that might be relevant: COPD, possibly metabolism of the liver. 26% of these cases had liver fibrosis prior to cirrhosis or cirrhosis, and some kidney disease. So looking at that, it's not a well group. Now, just before I just get on and just very briefly discuss what does it all mean, they're just the references. The studies were taken on the overall one, looking at by age, and the old man of science banging on about COPD, i.e. me. So now for your sins, you can look at me. What does it mean and what do we do? Well, a new senior demographic of people has arisen who are using heroin and who are dying from heroin. Tox is similar, yet they seem to have shorter survival times and high levels of disease. What to do? Well, treatment lowers the risk, and very few of these people in treatment. And there's no reason why someone who's 65 can't be in treatment, whether that be OST or a residential rehabilitation. And whether we're moving into the stage where we need to have methadone dosing in nursing homes, well, then maybe we do. rapid response is crucial. And one of the things that I'm interested is, colleagues have been talking about the use of wearable technology, because as I said, sometimes people collapsed in a room and people didn't know. With those alarms that people can wear, it can alert someone around that the person's not moving or they've collapsed. And as I've said, time's crucial here. And this is an intervention that doesn't rely on other people being there at that, right in the room with you. And finally, having taken naloxone is a no-brainer. Anyone who uses heroin should have naloxone at home. And now with the new nasal sprays, people around them don't need to be expert injectors. They can just give everyone really can give a nasal spray. They're as effective, and we know it's an effective intervention. And I should say that this goes for any opioid. If someone's using chronic pain medication, whether that doesn't really matter what it is, if it's an opioid, they should have naloxone co-prescribed or present. So they're just a few ideas. I'm sure you've got others, but that's really all from me. So, Sarah.
Oh, thanks, Shane. That was really interesting.
Well, I'm glad.
I've got some notes here, but thanks, Joe. I was just going to invite you to join us, Joe. So we might start then with you, Joe, if that's okay. Did you want to make any comments or reflections or shoot any questions to Shane to kick us off?
Yeah, look, just some thoughts here. Firstly, concerning geriatric medicine, and tragically, I think both Shane and I are falling into that category of late. But such is life. Firstly, the elderly, if I dare use that term, have different metabolism to young, sprightly creatures. Specifically, when it comes to opioids, opioids tend to have a longer half-life. So are they in fact dying earlier, or is it just a prolonged half-life? I don't know. Also importantly, as you age, your tolerance to opioids decreases. And I think anybody who's worked in an emergency department and given a patient 5 milligrams of morphine and seen them, suddenly go a bit blue around the gills, will know exactly what I'm talking about there. So I suppose one of the questions is are the dosages given to these older people the same as those in younger people? And possibly a suggestion should be put out there just to cut down on dose, because it can be more dangerous in the elderly. I think what we also see in this study is how much natural disease there is as you get older. Now, there's certainly a higher rate of natural disease in people who use opioids. In part, it's a lifestyle problem. In part, the ravages of tobacco and other substances, including the psychostimulants. Whether natural disease is contributory or not, though, I think is a difficult question to answer. I'm not entirely sure whether we're seeing this as incidental or if it's actually contributory. And to a certain extent, one of the things that's been really worrying me in relation to practices in the coronial system is how, as forensic pathologists, we're being told to do less and less internal examinations of bodies and to focus on external examinations, toxicology, and CT scans. Now, all of those are of great relevance in examinations, but the problem is that a lot of natural disease of the type we're talking about here is simply not identifiable or not quantifiable just by doing a CT, let alone an external examination. I like the idea of wearable technology, although it's a matter of knowing what type of wearable technology. I've been imagining a hypoxia monitor on your Apple Watch or similar. It shouldn't be that difficult to design, I would have thought. And of course, considering that respiratory depression is the major issue here, if you have a PO2 of, let's say, below 80, maybe an alarm should go off. I think that might actually work. Bystanders, very important, or lack of bystanders being the other problem. I think just finally, I think what we are also seeing is that we are probably undercalling the number of cases. Now, in part, as Shane showed, the dip in the last 5 years, that's not a genuine dip. What that almost certainly represents is that the cases have not been completed through the coronial system, so haven't been entered at this time in the coronial database. So I think that's of relevance. I think we've got a problem that probably people are being issued death certificates if they die in emergency departments or even in the community and homes by medical practitioners without there being a thinking of the possibility of heroin overdose at this age. Next problem is, even if they become coroner's cases, is toxicology necessarily done? And I think for many jurisdictions, doing toxicology in 100% of cases, it has major resource implications. And possibly we could be missing some under those circumstances as well. Just as a final thing, this, of course, related to heroin-related deaths, not all opioids. It certainly doesn't include the prescribed chronic pain medications, like oxycodone, etc. So again, in terms of if we are trying to extrapolate this to opioid deaths, I'm sure we'd be missing a lot of cases. And I think finally, and I've mentioned this concerning tobacco, and of course, methamphetamine as well has a significant effect on coronary artery disease and cardiovascular pathology in general. And I suspect long-term usage of methamphetamine in association with opioid use will probably increase the rate of cardiovascular disease and possibly have further effects on the lethality of heroin. Okay.
Oh, that's great. Thanks. You've picked up on a bunch of really interesting ideas there. Thanks, Joe. Some that I've got as well. Yeah, I'd be interested to discuss a bit more about the kind of natural disease idea, as well as the rapid response. But I'm going to do my job as a chair, and I'm going to actually start with the questions that are coming from the audience first. So this is, I think, a question to you both from Renee Bitton asking, do you know whether the cases were still smoking? Had they recently quit due to their COPD or cardiovascular disease? And then mentioning that, as you know, smoking affects plasma morphine levels through enhanced metabolism, such that if you quit, it might lead to overdose. So any thoughts about that? I actually wasn't aware of that, but I'm sure you both were. So any comments on that, if that's a potential contributing factor?
Well, in terms of the records, it's very hard to know whether people were smoking or not, because it's a coronial investigation. Some jurisdictions do test cotinine. I think Tasmania does, Joe, from memory, but generally it's not.
Yeah.
So no, I mean, we're relying on the records, and when they're trying to look at the cause of death, we're not necessarily getting that level of detail. Joe, did you have any comment on it?
Yeah, look, it's been one of my bugbears for the last 40 years. Getting toxicology labs to report on nicotine, or cotinine, depending which one you want to choose. And the general response is, but it didn't cause death, so why should we be looking at it? And of course, that's a totally fallacious argument, because in most car crashes, alcohol didn't cause death either, but it's obviously a major contributor, yet you test for alcohol. I've been able to persuade the toxicology lab in the ACT to look for nicotine as a routine. But unfortunately, yeah, I think it's pretty much a couple of small labs only that do it. Yeah, and trying to persuade the other labs to do it is just almost impossible.
It's interesting, isn't isn't it? Like, I'm just thinking, you know, it's part of the picture. You sort of got this snapshot in time that we're looking at from the data that this sort of research is based upon. Like, it almost feels like we need some case studies or some, you know, a bit more context around these circumstances. Is anyone doing any work like that, looking at sort of filling in the gaps in these stories and trying to answer some of these questions?
Well, the problem you run into is the issue of identifiability of cases, Sarah.
Yeah.
There's ethical issues, like for us looking at these deaths, we don't want to be presenting something that shows that this was a person who can be identified. Having said that, I think going back to Renee's comment and pursuing that, with living people, I actually think there is a role for, this is more like qualitative research.
Yeah, it is.
Like, I don't know, for instance, the rates of alcohol are lower than they used to be. Does that mean people have had liver disease and, you know, they've stopped drinking as much? Renee's question, does someone with COPD stop smoking? Well, probably not, but some might. But I think these are the sorts of things that I think that rather than looking at fatalities, I mean, because by definition, you got to be going to secondhand data, etc. Did you know if, you know, Joe Bloggs was still smoking? Well, I don't know. I think he might have. Do you know what I mean?
Yeah.
Whereas if you actually do the sort of, well, you know, Sarah, you're right across this qualitative research. It's the sort of thing looking at older people who are using heroin and look. But I also think just Joe's basic thing of just reporting nicotine, that would be helpful in partial. It'd certainly be answering the question that that was asked before, which was stated before, that was you know, were they smoking? Well, we can say it was in their blood at the time, and they had COPD, but we can't do that if the tox doesn't tell us.
Yeah, sure.
That would be group data, Sarah.
Yeah.
And I think the added problem there is as well that the history that you're relying on is provided by police investigating for the coroner.
Yeah.
So they're not health focused. They're certainly not health prevention or disease prevention focused. While they'll be focused in great detail on what might be on a wall or, you know, what might be found in a drawer next to the bed. You know, it's a totally different type of focus compared to what, in fact, we would like. After saying that, police reports can be an absolute goldmine of information.
Yep. I mean, they're medico-legal. I suppose the thing is the whole purpose is to find who died, where they died, why they died, and how they died. So it's a medico-legal process. But having said that, the police, in New South Wales, the P79A, and each state has a summation. They can be just a treasure trove of, you know, histories of mental health, talking to witnesses, what happened on the day. But they're not health professionals.
Sure. Yeah. Oh, sounds like we've identified a new research question that we need to tackle. That's great. Okay, we've got a bunch of questions. So Joe, I'm going to move to you now. We've got a question from Chris Donaldson who's asked, you mentioned in your comments, and I wondered this as well, that the external examination is being deprioritized during autopsies. Can you just talk a little bit around why that's happening?
No. It's not been deprioritized. The problem is that we are landing up doing more and more cases where we are not doing an internal examination. Okay, so effectively, the problem with that is that we have no real idea of the extent and severity of incidental natural disease to the death, or in fact might not be only incidental, might be in part causative. And the assumption is made really that finding a cause of death is good enough. Now, that's very different to finding the cause of death. And it's very much the case that if you don't look, you don't find when it comes to autopsies. and that you may very well miss significant disease. When Shane and I started this a few decades back now, autopsies were universally done in all drug overdose deaths. No ifs, no buts, they were just done. It's now, I don't know, probably sitting at, I would estimate 30, maybe 50% at most. And of course, you'll end up missing important information. Not so much specifically for that death, but you miss population statistics, that type of thing. But then the problem with the Coroner's Act, if you want to call it a problem, is that it's focused on the individual, not on a population. So a decision has to be made by the coroner on how to investigate a specific case with an emphasis on doing as little as possible, which is very different to most medical practice, I would have thought.
Can I just say, Joe's thing about like back in the 90s, when we were looking at full autopsy reports and early part of the century, it was that way we actually were able to demonstrate the role of cardiovascular disease in methamphetamine deaths and cocaine deaths, because we could say, look, these are all of the deaths, they all had autopsies, and I don't know, say 60% had severe heart disease. And we know that this drug causes it. That enabled us to be able to be confident and saying, this is a thing, this is a problem, and people weren't aware of it. So currently then, we got maybe 50-odd% getting them. Otherwise, it's just external over the circumstances, and rapid tox showed that they died of an overdose. But, I suppose the problem is we're coming from as health professionals. But having said that, Sarah, you've got to work with the cloth you've got, and we've got better cloth than anywhere else in the world, to be honest.
Yeah, I mean, you mentioned that, Shane, that this work isn't possible in the UK and the US. I wondered about that. Can you maybe just expand on that a little bit?
Well, what you have, for instance, in the United States, you get lots of papers that will be out of one county in one state. Right. Occasionally you may get one state, but they don't conglomerate national statistics. And ditto with the UK, they're getting a little better with drug-related deaths, but Scotland will be different than England and Wales, for example. And thus, a lot of our studies come out and you'll say, like this one, these are all the cases where in Australia, because during the 90s, and Joe was involved in setting up NSIS when he was a young, frivolous man in the 90s. And it was a real thing to get all of the various coroners in the different jurisdictions to contribute these documents. So now they all do. So each state, I would have cases from Western Australia, the ACT, New South Wales, wherever, because they're all contributed. And it took a lot of work for them to set that up. But what it means is we have a national database, and you cannot do that in, say, the United States.
Sure, yeah,
whereas you can here. So that's the bottom line. Sure,
yeah, great. Thanks for clarifying that, Shane. I wondered that as well. Okay, we've got a few more questions, so we'll try and get through a couple. I've got one here from Mikey Hughes. So this one is asking about access to OTP. So this is treatment. Sorry, Mikey's saying that we've had experiences here where older people have reduced ability to get around. So I think this is, reduced ability to travel, to drive, that sort of thing. So finding access to OTP can be harder.
Yes.
So just wondering if either of you had any thoughts on that, and if you're aware of any programs that are focused on, taking treatment to people rather than people coming to treatment, I guess.
Look, I'm not a clinician, so I'm not aware of that. I do think that Mark's issue is valid, and particularly if you looked at the health of the people we're talking about, say someone who's got heart disease, got COPD, mobility problems in their 70s, and they're opioid dependent, and we know that treatment can reduce their risk like 30-fold, then I think, we have people going, I mean, this is probably where drugs such as buprenorphine depot come into their own, where you can give, these are long-acting drugs, subcutaneous, and you might have buprenorphine, which has lower respiratory depression than methadone. It's a substitute opioid, but it can have a depot that lasts for, say, 30 days. So the person doesn't have to be going in to get dosed every couple of days or with methadone every day. I mean, there is, of course, take-home methadone, but with older people with respiratory depression, buprenorphine's a good choice. But you're probably looking at, rather than someone going out, which we come back to costs like we do with the autopsies, going out every day to dose someone, you could give, if someone's stable, give them a buprenorphine depot injection and they'll be right for a month. I don't know, Joe, what do you think about that?
Yeah, I think that's an entirely reasonable suggestion. I mean, I don't know how buprenorphine behaves in the older person, especially as a depot, but yeah, it seems reasonable. I don't know.
Thanks.
Or patches are another alternative.
Yeah.
Sure, thanks. The next one I'm going to pick up on here is from Cliff, who's asking, this one's for you, Shane, but Joe, feel free to chime in as well. Asking about the fourth wave occurring overseas. So any thoughts about the number of overdoses that may have been related to methamphetamine co-use with opioids, underlying acute or chronic methamphetamine-associated cardiovascular condition? Thanks, Shane.
Look, back in the day, we used to always think, hold it, and I think it's tend to think opioids are depressants, stimulants are stimulants, and therefore they won't interact. The problem you have is twofold. One, as Joe's pointed out, a lot of heroin users over the years have used methamphetamine and cocaine. It causes cumulative heart damage. So we know that, and we know that that can put the person at risk of oxygen deprivation of an arrhythmia. But we also know, if you think about it, you've got a drug, you take methamphetamine, it's increasing the heart's demand for oxygen, and you've taken another drug that reduces the amount of oxygen coming to the heart. So there are good clinical reasons why that combination can be quite dangerous, even though possibly the people using those drugs think, oh, these are, you know, up and down, and that's a nice balance. It actually could be contributing to a death. So I think they're right. Joe, I don't know what you think about it.
No, look, I agree that the combined taking of these two categories of substances is probably a very bad idea, all in all. Cardiac arrhythmia is very much increased in rate in people in a hypoxic setting. Yeah, and arguably, if you've got increased cardiovascular demand with methamphetamine and other stimulants, the last thing you want is taking a substance that decreases oxygenation.
Great, thank you. Okay, we've got one here from Tim, who's asking, I mean, it's a good point. There's sort of this common understanding that older users or longer term users have more tolerance. But what we're sort of saying today is that, in fact, as people age, the tolerance decreases. And that, you know, that's sort of interesting from a messaging point of view, as well as for clinicians to think about discussing with their clients. Did either of you have any thoughts on that, or if there's any ideas around getting that messaging out to people who are using these drugs or to professionals who are working with them?
I think it's a really important point, but I think possibly one of the reasons that it's not, I doubt if it's being discussed a lot, is because, as Joe was saying about cause of death, and we're talking living people here, but people don't tend to think if someone's 75 that they're using. And of course, we know if people are being prescribed fentanyl or people are going to be very careful with older people. I think a discussion, if you got someone, say in a treatment setting, you know, are you still using, you know that you can't metabolize. The idea that your metabolism increases with age is sort of, it's mixing up early onset, you know, it's mixing up lifetime tolerance with current. And one thing I'll say about tolerance is that the tolerance to the effects, the hedonic effects, occurs far more rapidly, and the oxygenation effects of the breathing suppression, you never develop the same degree of tolerance. So people are using more to get happier and get the same effect, but it doesn't mean that their tolerance to the breathing cessation has gone up. And in fact, from everything we know, it's the opposite, and the message needs to be the opposite.
Yeah.
Yeah, I think the other thing there is I'm not that certain that you develop increasing tolerance over time.
No.
You lose tolerance very quickly,
Hmm.
probably within a couple of days to a week or so. And you have to start again at square one, in terms of increasing your tolerance again. So I don't think that, after you've used heroin, let's say, for 10 years, that you're more tolerant than if you've been using for 1 year, let's say.
No.
And, you're not super tolerant after 50 years.
No.
Sure. Yeah, excellent. Thanks. Look, we're nearly out of time, but I've just got one, I think, very quick question from Crystal that I'm going to try and squeeze into the last couple of minutes before we need to wrap up. Crystal's asking about, was there any information in the reports about treatment for any of these physical conditions or physical comorbidities? And I think this kind of comes back to a little bit to our case study qualitative research question that we were discussing before.
It would be relying on being mentioned, and typically that would be whether there were, and I didn't report it here, the sort of information we get, whether there were blood pressure medications on board, antiarrhythmia drugs on board. The general picture, however, was that this was an undertreated group of people. They're a very isolated group of people, Crystal, and particularly older people. A lot of their friends, they've outlived a lot of their friends. They're quite isolated. And as one of our other questioners said, it's a matter of getting anywhere too, to get treatment. So my general view was these were people in poor health and probably undertreated, would be my guess.
I'd agree with that.
Excellent. Oh, well, that's a really nice spot to stop. So I'm going to just wrap up here and really thank you both, Joe and Shane, for taking the time today to meet with us. It's been a really interesting discussion. I mean, there's lots of discussion happening in the Q&A, and we haven't quite got to all of it, but we've done our best. So if there's any questions that are unanswered or anything that you've got a burning desire to discuss with Shane, I'd encourage you to get in touch with Shane directly or through our comms team to keep the conversation going. So thank you again to Shane and Joe for today's webinar.
Pleasure.
Thank you. Pleasure.
So coming up next week, we're actually taking a break, so you can have your hour back on Thursday afternoon. And then the following week on the 21st, we're going to be joined by some friends of NDARK from Anke van der Stern and Chris Goff, who are going to be presenting on service users experience measures of services in ACT. So we'll really look forward to seeing you on August 21st for our next webinar then. And also just a reminder that our symposium is coming up in September. We hope to see you face-to-face there. So thanks, everyone. We'll see you in 2 weeks.
Thank you.
Thank you, Sarah. Thank you, Joe.
Right. Bye-bye.